Welcome to Cardiology 305. Today we're diving deep into one of the most controversial topics in heart health, alcohol and cardiovascular disease. I'm Dr. Fernandez, and this presentation is packed with the latest evidence, from the famous J-curve to game-changing genetic studies. By the end, you'll know exactly what to tell your patients or yourself. Let's get started. Here's our roadmap. We'll cover the epidemiology and the famous J-shaped curve, break down effects on a specific heart condition, explore mechanisms and special populations, review drug interactions and screening, look at the guidelines and the benefits of cutting back, then finish with clear take-home message and full reference. Buckle up. This is going to challenge everything you thought you knew about that nightly glass of wine. Alcohol and heart disease. It's been debated for decades. All observational studies painted a rosy picture of light drinking being protective. But modern genetic research is flipping the script. Today we'll separate correlation from causation and give you rock-solid evidence-based advice. The J-shaped or U-shaped curve observation data. Classic observational data show a J-shaped curve, light to moderate drinkers, up to 1 drink a day for women, 2 for men, appear to have 14 to 15% lower risk of coronary artery disease. The big 2018 Lancet analysis of nearly 600,000 drinkers found the lowest mortality around 7 drinks per week. Sounds great until you look closer. Nuance with the J-shaped curve. Here is the catch. The apparent benefit was mostly limited to heart attacks. Higher drinking raised risk of stroke, heart failure, and other problems in a straight line. So, the dip in the J-curve wasn't as protective as it looked, and that's where genetic comes in to spoil the party. Wood and colleagues in the Lancet 2018 analysis individual data from the 599 current drinkers across 83 studies. Lowest mortality at about 100 grams of alcohol per week, roughly 7 drinks. But they also highlighted the big problem with these studies: healthy user bias, lifestyle confounding, reverse causation, and people not accurately reporting how much they really drink. Mendelian randomization challenge causality. Now for the plot twist. Mendelian randomization uses your gene as a natural randomized trial. In a huge UK biobank study of 278,000 people, every extra genetically predicted drink increased all-cause mortality by 27% and cardiovascular mortality by 30%. No protection at low levels. No J-curve, just linear harm. This is why we say correlation is not causation in medicine. Similar findings pop up in the Million Veteran Program across multiple ancestry. No causal benefit for heart disease or diabetes in Chinese men with AUDIT-C gene variant. Higher genetically predicted alcohol meant higher cardiovascular risk. The evidence is stacking up against the old modern good story. Bidinger's team showed that once you adjust for healthy lifestyle factors, the observational benefit shrinks dramatically. Their nonlinear genetic analysis revealed minimal risk at very light intake, but exponential risk as drink increases, especially above 7 drinks per week. The curve isn't protecting you, it's mostly tricking us. Cardiovascular effects by disease entity. Let's get specific. How does alcohol affect different heart conditions? We'll cover coronary disease, atrial fibrillation, hypertension, stroke, and heart failure, each with its own surprising data. The 2025 AHA statement notes that observational studies still suggest lower heart attacks risks within guideline limits, but methodological issues make causality shaky. A burden of proof of meta-analysis found small reduction in cases control and cohort study, but Mendelian randomization studies show no real association. The protection is fading under scrutiny. Coronary artery disease and myocardial infarction, part 2. The 2023 AHA-ACC guidelines is crystal clear. All the benefit data are observational and confounded. They say we do not have enough evidence to recommend alcohol for heart protection. Bottom line, don't start drinking for your arteries. Atrial fibrillation. Alcohol is well-known trigger for atrial fibrillation, and there is no clear safe threshold. Just 6 drinks a week raises risk, and binge drinking can spark holiday heart syndrome, that irregular rhythm after a big night out. Your heart doesn't love surprises. The landmark trial was eye-opening. Regular drinkers averaging 17 drinks a week who were randomized to abstinence had significantly less atrial fibrillation recurrence and lower burden. The abstinence group spent way less time in irregular rhythm. If you have AFib and drink, this is a powerful motivation to cut back or quit. Hypertension. Alcohol and blood pressure have an almost linear relationship. Risk rises steadily, 11% higher at 22 grams per day, 22% at 36, and 33% at 48. We even see a steeper increase. Every extra drink is quietly pushing those numbers up. Stroke. The Interstroke study showed high and moderate drinking increase odds of all strokes type. Heavy binge drinking raised overall stroke risk by 39%, and intracerebral hemorrhage by a whopping 76%. Not exactly brain friendly. Heart failure. Long-term drinking, 7 to 15 drinks daily for years, can cause alcoholic cardiomyopathy. Women are most vulnerable at lower dose. Even in people with existing heart issues, 5 or more drinks a week can push them toward symptomatic heart failure. The heart muscle simply does not like chronic alcohol exposure. Biological mechanisms propose beneficial effects. Scientists once thought moderate alcohol boosted HDL, lower fibrinogen, improved insulin sensitivity, and helped blood vessels via nitric oxide. Red wine, polyphenols like resveratrol look promising in lab study. Sounds perfect on paper, but the harm effect dominates. Direct toxicity to heart cells, oxidative stress, atrial scarring that promotes arrhythmia, blood pressure elevation, and inflammation that speeds atherosclerosis. When we properly control for confounders, the benefits don't hold up clinically. Beverage type. Red wine often looks best in observational data, but that's largely because wine drinkers tend to have healthy lifestyle overall. UK Biobank's data show beer and spirits linked to higher risk even at low levels. The AHA says no specific beverage is recommended for heart health. Sex difference. Sex matters a lot. Women reach increased risk at much lower doses. Protection peaks around 11 grams per day and risk rises at only 14 grams. Men tolerate higher amounts before risk climb. Biology and body size make a real difference. Special population, genetics, and ethnicity. Genetic can dramatically change the story, especially the ALDH2 variant common in East Asia, which makes even moderate drinking harmful. In China, alcohol contributes to a large share of stroke in men. In the US, some ethnic groups face higher alcohol-related harm. Personalized counseling is the key. Alcohol interacts dangerously with many heart meds. It raises bleeding risk with warfarin, prolongs effects with verapamil, and boosts propranolol levels, causing low blood pressure or slow heart rate. Nearly 80% of older adults are on interactive medications. Always check. Statins plus alcohol increase liver risk. Aspirin with a few drinks can dangerously prolong bleeding time. Routine medication alcohol review should be part of every cardiology visit. Screening for unhealthy alcohol use. The USPSTF recommends screening all adults 18 and older. 2 quick tool, AUDIT-C, 3 questions, 1 to 2 minutes, and the single alcohol screening question under 1 minute. Simple, fast, and effective. Cutoff are gender specific, greater than or equal to 3 for women, greater than 4 for men on AUDIT-C. Positive, follow up with a full 10 questions audit. These tools reliably separate low risk from risk drinking or alcohol use disorder. Clinical management, brief intervention, brief counseling, just 1 to 2 for section totaling about 30 minutes is increased incredibly effective at reducing unhealthy drinking. It ranks among the highest impact prevention service we can offer. Short conversations save lives. Pharmacotherapy for alcohol use disorder. For patients with alcohol use disorder, FDA-approved options include naltrexone, acamprosate, and disulfiram. Combined with counseling, this tool gives patients a real fighting chance to cut back or quit. The 2025 AHA statement is clear evidence is insufficient to recommend alcohol for cardiovascular protection. Focus on exercise, not drinking. The 23 chronic coronary disease guideline says limit intake if you already drink, but never tell patients to start for heart benefits. The WHO Global Burden of Disease analysis concludes the safest levels for most people is zero or very close to zero. Global consensus: alcohol is not a heart medicine. Good news: reducing heavy drinking cuts major adverse cardiovascular events by 23%. A specific reduction: 29% lower coronary artery disease risk, 30% lower angina, 34% lower ischemic stroke, and 21% lower all-cause death. The benefits are real and measurable. These improvements start showing up around 3 years after cutting back and last over a decade. Blood pressure can drop noticeably within just 1 month of abstinence. Consistency across subgroups makes this incredibly encouraging. Abstinence reduces atrial fibrillation recurrence and burden is essential for alcoholic cardiomyopathy recovery. Even in established heart disease, lower intake is linked to better outcomes. Cutting back is one of the most powerful moves you can make. In clinic, screen everyone with AUDIT-C or SASQ at every visit, giving brief counseling when positive. Never recommend starting alcohol for heart health. Advise strict limits or abstinence for patients with atrial fibrillation, heart failure, or cardiomyopathy. Always review medication interaction and individualized by sex, genetics, and comorbidities. Final takeaway points. The J-curve is largely an illusion. Mendelian randomization shows linear harm with no safe protection zone for most outcomes. No amount of alcohol is proven cardioprotective. Routine screening and brief interventions are high yield. Prioritize exercise, healthy weight, and not smoking. Counsel smart, counsel often. I've included a complete reference list in the slides and speaker notes for everyone who wants to dive deeper. All data here comes from direct from high-quality source, including the 2025 AHA statement, major MR studies, and landmark trials. Feel free to pause and screenshot any citations you need. That's it. Alcohol and heart disease, a topic full of myth and now backed by much clearer science. The message is empowering. Small changes like cutting back or quitting can deliver big heart benefits. Thanks for watching. Drop your question in the comments. I read them all. Like, subscribe, and share it if this helped clarify the alcohol